No, Mariana.
So the next case is the case of a 21-year-old woman who, unfortunately, despite her young age, underwent vertical banded gastroplasty for obesity in 2007, followed for sleeve gastrectomy in January of this year for weight regain. She presented in April with abdominal pain, and an MRI showed a large paragastric left subphrenic collection, which was consistent with a gastric remnant. And so she underwent EUS-guided drainage with insertion of 2 plastic double pigtail stents, which drained this collection. Her outcome was good. She didn't have any more pain. MRI showed that there is still persistence of a collection, and the stents were still in place. So this patient is scheduled today for insertion of metal Diabolo stent for long-term drainage of this gastric remnant, and we can join now Jacques Devière and Marc Giovannini for the procedure.
So, welcome. You see that Marc has the position of the teacher who is watching his student, and I think it's very important to this kind of relationship between friends. So we are here in you see that we already did a puncture in this lady who had no chance with medicine, and you understood that she has, if you have the fluoroscopic image she has a remnant of the stomach which was forgotten during surgery.
Yeah, this one is good.
Which is a very huge part of the fundus, which has been isolated from the sleeve gastrectomy. And even a redo of surgery was not able to remove this area because the lot of leaks, infection the patient had. So we really plan to try to get a long-term, establish a long-term communication between the isolated pouch and the sleeve. So you see that I have a Simon needle inside the sleeve inside the pouch. We have removed the 2 plastic stents, which were obviously not enough to provide sufficient drainage, but the patient was going better, but still had some symptoms, especially pain in the left shoulder. And you see that its Marc is turning a little bit the scope.
Yes.
You see that the collection has also some fluid content here.
We need the ultrasound image, please.
The US image is very interesting.
We don't have it.
We don't have it. We need the ultrasound, please. One moment, Jacques, we do not have the ultrasound image yet.
If there is somebody at the regie, we would like to have the ultrasound image.
Okay. We have it now, Jacques.
Okay, so we have the double layer there. You see the collection there.
And this is the gastric, collection. It's with the gastric wall, and this is full of liquid. Huh?
And then if you turn back, you see this double gastric layer here with some hyperechoic area in between, which is probably just a fault,
yes,
as Marc suggested, of the gastric wall.
Because the fundus part is probably dilated, and there is a kind of kinking of the stomach.
So now we will proceed with the drainage. So we removed the plastic stent, but I did a new puncture, and you see that I'm using the Olympus EUS scope. Sonia has a...
Now the X-ray image will be better.
As a guide wire, so you can switch on the X-ray image, please. We don't need the fluoroscopic image.
Is the variation of EUS guided pancreatic collection, that technique that you use.
So now I'm coming with the cystotome. It's in AutoCut Effect 5, so almost pure cut. And I will try to enter the collection with the cystotome, which is relatively easy when we have the good settings. Marc, I didn't realize in a previous exam that I had given you the wrong settings. And now we will remove the system, because the next step will be to try to place an X-Lumina stent. So this Diabolo stent There are several Diabolo stents which are available. We have chosen this one because this is very atraumatic, and probably this young lady will have this stent for a while, so we will just wait for the...
You have also different size, hein, Jacques?
Yes, this is, we choose what I think is the largest one, is 15 millimeter in diameter, and this is a stent that we use also when we have to go back and forward in a cyst collection to do a necrosectomy.
And you have some different lengths. This is 1 centimeter length between the two flap and the two flange.
Je te donne la valve?
Oui.
So you
But
see
this stent should be inserted only with the US scope, because it's adapted for the US scope. The length of the device, which is a 10.5 French device, is adapted for the length of the US scope.
This is not the first patient we have with this kind of complication after bariatric surgery. Probably we concentrate them, but I think that we surely have treated 8 or 9 patients with this problem of isolated gastric pouch, which very often occur after a sleeve or sometimes a bypass, but more often a sleeve, which has been previously operated from another intervention and mainly from a lap band.
There's a question from the audience, Jacques. How long will you leave the stent in place?
I will not remove the stent. So probably the stent will migrate by itself. From the small experience we have, most of the stents which have migrated without any complication, but without any relapse, because probably when we place very large stents like these ones, they establish a long-term drainage or long-term anastomosis. So you see that this stent is for the people who like the numbers. So the first thing is to adapt, where you open that, is to adapt the length. We have to remove that too, no? Okay, and then I have to push the stent in.
Completely.
I have to push the stent fully in, so this is the introduced.
Not fully, but I think the two-thirds, I think this is okay. This
like
is
that?
enough.
So the stent opened is inside. Then the second part is to remove that, which is a blocker.
Yeah.
You see, I hope that you have a view on the camera. You see you have numbers on the stent, and then the number 2. So I will unlock
and deploy
the number 2. It will be
to deploy the first.
To deploy the distal flange of the stent. You see, up to the
yes, beautiful.
Up to the number 2. Then
now you have a click.
You have another click. That means, as you see on the fluoroscopy, that the distal flange is deployed, and now you should have both the fluoroscopic and the EUS picture. So now I will pull back the whole system close to the wall, and you see that I have a view on the endoscopic image and on the
US image. Also in the endoscopy, if you want to see the black marker, because you have a black marker.
And then now I must go back, because there is a black marker that I should see
before to deliver the second.
So this is of course the problem when we are working in a sleeve gastrectomy, because we have not much space to see it.
Can we have the endoscopic image, please?
Yes, you will not see anything, but you may have it. Okay, here we are.
Ah, yes.
So I'm turning a little bit. I would like to see the stent. I'm sorry if it's a little bit difficult, but I don't want to move too much because otherwise I will completely lose my position. Here it's probably good, but va sortir. Quoi?
Ça insuffle ton CO2 là.
I think I've seen the black marker there very transiently.
Attends.
So if I've seen the black marker, that means that I can go for the third part.
Non, il faut tirer, il faut le...
I can pull back again a little bit more. Close.
No, close now. Voilà.
Huh?
Now you can deliver the...
Then I pull back. I must be at a distance. I don't want to have everything migrating into the cavity, otherwise I will have to go back. Pardon? And then I will deliver the stent. This is open, so this is fully open. And then it should be released.
It's perfect.
Okay, that's a little bit tricky in this particular indication, but finally we did what we wanted to do.
Perfect.
We established this communication between the pouch and
Jacques, will you now balloon dilate the stent or let it self-expand over time?
No, I will let it self-expand over time, and I'm quite sure that within a few days it will be fully expanded, and I think it's even better for the stability. So I will let the stent open by itself.
This is different if you use this stent for biliary, for choledochoduodenostomy or for cholecystoduodenostomy or gastrostomy. You should dilate if you want to have a good drainage. But I think here it's probably different.
Okay, so we can maybe inject at the end, but I will remove the wire now. I have to remove everything, and then. But I think that the procedure is almost finished. If you want to move to another place.
Do you plan to next control to go inside with a gastroscope to clean, or?
Of course, we can go if we are curious. But it will not help the patient. You see the fluid which is coming?
Yes.
There is pus coming out. Huh?
There was pus when I drained her for the first time, because at that time it was an abscess. No, it's probably still a little bit infected.
It's a liquid,
and we
gastric
can.
liquid.
I will try to inject to convince you. Fluo, please. If you have the fluoroscopic image.
Yes, we have.
That we are going to the stomach there. You see that now we have a nice view of the large communication we have created.
Fantastic.
There is a question from the audience. What should be the follow-up for this patient?
Mainly a clinical follow-up. If the patient is going well, I would like to see her back in 1 year. She's coming from Egypt, so I will not ask her to come every second week. If she has other problem, of course, I would be ready to see her before. But in 1 year, I would do a control to see if the stent is still there. And if the stent is still there, I don't worry, and I would leave the stent for another year or another 2 years. So this kind of stent, because they are relatively atraumatic, I think, can stay probably in place for a long time. And if the stent has migrated, I will not do an exam if the patient is asymptomatic. That would mean that there is a fistula which is remaining patent, and then we have no intervention to do. So the only need for intervention would be clinical.
Jacques, essaye de le maintenir parce qu'on va se poser quelques questions.
Yeah.
On répond commentaires qu'on n'est pas prêt.
So we have, you know that the world of management of surgical complication after bariatric surgery is large, and we started placing stents and trying to close fistula. But even for some leaks now, you know that when you have the leaks which have not been drained by the surgeon, so which are ending with an abscess at the level of the subdiaphragmatic area, a good treatment is also to create a communication a little bit like a cyst drainage or an abscess collection drainage. And sometimes it's even better to do that than to re-establish an external drainage and to place a stent. If it is frequent to have gastric
remnant with sleeve.
Remnant.
Yes, as I mentioned, this is not frequent, fortunately, but it occurs. It's one of the classical complications, which is often taken and mistaken for an abscess, because there is a collection which can be full of pus. But when you see on EUS, you have the clear diagnosis of a double layer. And the particularity is that it's an abscess which is impossible to treat by drainage because it's continuing to secrete gastric secretion all the time. So the only way to treat this patient is to establish this kind of communication or to remove the remnant. But because this complication is more frequent after a previous surgery, a redo of surgery, very often lap band followed by a sleeve gastrectomy, then the surgery intervention is extremely difficult and associated with a lot of complications. If you see the history of this lady, this is typically the history. First lap band, complications after the lap band, a redo of sleeve gastrectomy, which was done probably by somebody who was not the most experienced, and you know that when they do sleeve gastrectomy, the surgeon, they do not see the upper part of the dissection.
Jacques, I have a question because obviously this needs to be a permanent communication. Do you think there's any chance that that with this stent indwelling for a reasonable length of time, that you will actually get epithelialization and get a chronic fistula that won't close when the stent comes out? Or do you think that there's a role for magnets? If you could get magnets on both sides, would those allow for a permanent communication?
So there are two questions. Yes, my hope is that on the long term we will get a complete reepithelialization of gastric wall. This is what we see, but nevertheless, because we have two muscle layers and very often two serosa, there is a tendency of stenosis of this communication that we are doing. The magnet is a good idea, but as I mentioned, our use of magnet is purely experimental. But it would be extremely difficult to cut through two layers. So it would not be my first choice. I think that these large stents are a very good opportunity to try to establish a long-term communication. And from the small experience we have, with maximum of 2 years follow-up, this is going quite well because no patient had to be reoperated on for relapse of collection after placing such stents in the isolated gastric pouch. I'm not a fan of this Diabolo stent for all the cyst collection, and I think that there is an over-promotion which is done about these stents. I think that the major indication is necrosectomy, but this is another interesting indication where these stents are bringing something more than what we didn't have with the other stent, because we were only able to place straight stent, and this design, especially with the atraumatic curves in the proximal part, is probably interesting in this indication.
Do you think that this technique could be an option in patients with bypass? We develop, for example, bile duct stone to create a passage, and after to come back with the duodenoscope to do an ERCP, or it's purely
No,
funny
I think it would be making difficult something which is relatively simple.
No, because this paper was...
yes, I remember. There was a paper where the people were proposing to go through the wall in a bypass in order to have a transient access to the papilla, then to close it, and I think it's not a good idea. So I was speaking a lot because we were waiting for the next patient. The next patient is ready, so we can...
Well, thank you, Jacques. Thank you, Dr. Giovannini. We move to the next